After the publication of the 2025 classification of dystonia, I have received several requests for comments and clarifications from colleagues located in different parts of the world. I have also presented some lectures explaining the intense work performed by this panel of experts over 2 years of intense data analysis and synthesis. I think that this information may be of use for many colleagues and thought to propose it on the wider internet audience. You will find here one presentation I have recently assembled on this topic.
I provide here my personal analysis of the recently published classification of dystonia. This publication appeared in 2025, although it was meant to appear in 2023, 10 years after the original 2013 classification. It took longer than we expected, of course. The name dystonia dates back to 1911 when two publications were published on the same type of phenomenology, one by Oppenheim, who was a leading neurologist in Germany at that time, the other by Flatau and Sterling, who were from Poland. The publications were both in German language, and described the same type of condition with different names. Dystonia was the name proposed by Oppenheim, who thought that there was an abnormality of muscle tone, whereas Flatau and Sterling focused mainly on the progressive torsion spasm that they observed in these children. Oppenheim, whom you see here on the right, described these children with generalized dystonia. We use this term generalized now. He just spoke about dystonia. And what happened is that there were other conditions that had been independently described, particularly blepharospasm, torticollis, spasmodic dysphonia, writer's cramp. These were independent publications, independent descriptions that were not at all considered connected to the phenomenology of these children with diffuse involvement and generalized dystonia, as we say now. My former mentor, David Marsden, whom you see on the left, proposed for the first time in the first conference on dystonia that was held in 1975 in New York to lump together these forms of specific involvement, what we now call focal involvement, into the larger set of dystonia. He said these are incomplete forms of dystonia that are within the larger set of a pleomorphic condition that we can collectively call dystonia. So focal forms of dystonia for the first time became the same condition as generalized dystonia. And blepharospasm is now called cranial dystonia. Torticollis is the better term now is cervical dystonia. Laryngeal dystonia is a better term for spasmodic dysphonia, which was at times also called spastic dysphonia. And limb dystonia is a general term for what used to be called, and still is to some extent, writer's cramp. This is the slide that David Marsden showed in 1975 in New York. He identified three levels of body distribution. Focal dystonias involved only one body region and at that time had specific names that indeed have remained until now. Segmental dystonias had involvement of two or more body regions, and in the end, generalized dystonia had a diffuse involvement of the body. He also considered more common associations and identified these by drawing solid lines, and less common associations that he identified by drawing dashed lines. So from that moment on, the idea of having three levels of body involvement developed. Generalized dystonia corresponded to the original descriptions by Oppenheim and Flatow and Sterling had the specific name of dystonia musculorum deformans. Segmental dystonia had some specific names such as Mage syndrome or craniocervical dystonia. Focal dystonias had several specific names such as blepharospasm, cervical dystonia, spasmodic dysphonia, or writer's cramp. Let's move on to the definition of dystonia. Recall here the two different definitions that were developed by Oppenheim on the one hand and by Flatow and Sterling on the other hand. They depicted with completely different words the same phenomenology. These definitions were, however, very innovative considered to the descriptions that had preceded, such as tetanoid chorea, tonic cramps with hysterical symptoms, and torsion neurosis. The definitions that followed try to point out some specific aspects of the pleomorphic appearance of dystonia. Hertz identified the movements, dystonic movements, that he described as slow, long sustained, and turning. Denny Brown was more struck by the postures that he called attitudes. Fan and Eldridge provided the first modern definition of dystonia with sustained involuntary twisting movements that could be fast or slow. And we in 2013 provided a still more developed definition. I remember that Stanley Fan was part of the committee that developed the 2013 classification, and dystonia was then defined as composed by sustained or intermittent abnormal movements, postures, or both. I have tried here to summarize which definitions mainly focused on the postures of dystonia and which mainly focused on movements. You see that in red, P indicates definitions that were particularly emphasizing the postures, and with M in blue, the definitions that particularly emphasize movement. It can be seen that the 2013 classification for the first time really emphasized both postures and movements. And in that sense, it was the first modern definition of dystonia. But still, when we look at pictures, we are struck by the observation of abnormal postures that are the easiest details to be reproduced in iconographic terms. The definition of dystonia that we published this year is not very different from the definition that was published in 2013. This slide shows which are the main differences. Both of them are composed of three sentences. The first says that dystonia is a movement disorder characterized by sustained or intermittent abnormal movements, postures, or both. So we repeat the idea that there are movements, there are postures, there can be both, or there can be just one of the two conditions. That changes from one patient to the other and explains why we see pleomorphic phenomenologies. The second sentence states that dystonic movements and postures are typically patterned and repetitive and may be tremulous or jerky. This or jerky was added to the previous definition dated 12 years ago. The third statement says that they are often initiated or worsened by voluntary action and frequently associated with overflow movements. So dystonic movements and postures have this third characteristic. Compared to the 2013 definition, we deleted the reference to muscle contractions in the first or in the third sentence and deleted the mention to twisting in the second sentence. The reason for deleting muscle contractions was that it was perceived that muscles are, of course, involved in any type of movement, whether voluntary or involuntary, and overemphasis on the muscles was probably inappropriate for a condition that is generated by the central nervous system. It could have been misinterpreted. There are also other aspects. Botulinum toxin injections, which are a treatment for dystonia, are often targeted to muscles, and this may have led to additional misinterpretation. Also, dystonia in some European language, particularly Latin languages, sounds like dystrophy, and this could have been a cause of misunderstanding as well. In the end, muscles are of course involved in dystonia as an endpoint because each type of normal or abnormal movement, of course, has to involve the muscles. And also twisting was deleted because it was considered that it wasn't so clear to emphasize the twisting nature of the movements. It was more important to emphasize other characteristics. So to summarize the specific feature of dystonia, we recall dystonic movements, dystonic postures, or both. We also have to remember that these can be sustained or intermittent. And then dystonic movements and dystonic postures can be patterned, repetitive, can be tremulous, can be jerky, or neither of the two. And I will get back to this particular feature. Movements and postures are typically activated by voluntary action and are typically associated with overflow. Let's take a look now to the classification of dystonia and to changes occurred between 2013 and 2025. The 2013 classification of dystonia was really innovative because it introduced the concept of two axes. Axis 1 reporting the clinical characteristics without linking them to any etiology. So we could find there historical information on dystonia, the phenomenology of dystonia, and features that are combined with dystonia in some specific conditions. Axis 2 instead reported the information relevant to etiology, such as the observation of pathogenic gene variants or pathogenic environmental events or pathogenic anatomical evidence. In both axes, the emphasis was on dystonia, so we concentrated on what was relevant for it. It was a very innovative idea and a big effort because earlier classification systems reported a mixed phenomenology with etiology. For example, the classical expression primary dystonia meant a dystonia of unknown etiology and with no other combined condition. So we got rid of a number of terms, not only primary dystonia, but also, for example, pure dystonia or the very confusing expression dystonia plus. This is the organization of Axis 1 in the 2013 classification. One item was age at onset, with 5 different ages at which the disease could start. A second item was body distribution, recognizing focal, segmental, multifocals, generalized, and hemilateral dystonia. A third item, which was very innovative at the time, was the temporal pattern, distinguishing the disease course as static or progressive and the variability as persistent, action-specific, diurnal, and paroxysmal. The fourth item on axis 1 was the associated features, whether dystonia was isolated or combined, and whether there were any additional neurological or systemic manifestations. The new classification system has 6 main divisions compared to the 4 of the previous classification. The additions are shown in green and correspond to family history and phenomenology, but there is also another addition under the temporal dimension, which is onset of dystonia. These items are marked as new in the future slides. This picture also shows that there are items marked in blue here in the body distribution, multifocal and generalized particularly, and combined features are also marked in blue, which means improved. You will find improved in the next uh, slides to raise particular attention on these items that have been really changed compared to the previous usage. Otherwise, all the classification has been revised and there are a number of improved wordings and details. Let's look at the innovations. Family history here includes the reconstructed family tree based on history taking, what the patient tells us or what the family or caregivers tell us about the familial occurrence. On the temporal dimension, we have onset of dystonia that can be acute, subacute, or gradual. And phenomenology is a completely new addition, mainly related to the idea that now the classification will be used also by non-expert in dystonia or colleagues who may be just junior and eager to have a listing of what phenomenology are we pointing attention to. Also, this category of phenomenology introduces a particularly detailed listing of additional characteristics, not only alleviating maneuvers, which correspond to what is otherwise called sensory trick or gest antagonist, but also the tremor-like appearance of dystonia. We saw in the definition that there can be tremor-like appearance, and the jerky-like appearance of dystonia, we saw also that this was added in the definition of dystonia. So we now recognize that dystonia can appear very much as tremor and very much as myoclonus. This raises the need to distinguish cases where we have a dystonia appearing as jerky or myoclonic from a dystonia which is really combined with myoclonus. That means with a different movement disorder that adds up to the phenomenology of dystonia. In the first case will be isolated dystonia appearing as jerky phenomenology. In the other case will be a combined dystonia, including dystonia, not jerky or not necessarily jerky, and myoclonus. The same is true for tremor. We can have tremor-like or completely tremulous dystonia, patients who just have what looks like tremor and is otherwise a phenomenology of dystonia, or patients who have dystonia with or without tremulous appearance, combined with an otherwise additionally added uh, movement disorder, in which case will be tremor. It's not easy to distinguish these two occurrences, which are synthesized by this picture here. You see tremor in blue, that can be a tremulous-like appearance of dystonia, or tremor plus dystonia added up to dystonia. And also myoclonus in red, which could be a jerky-like appearance of dystonia or myoclonus added up. to dystonia. For example, in patients who have variants in the CE gene and have myoclonus dystonia, we consider this a combined form where myoclonus is added up to dystonia itself. More difficult the distinction is for tremor because tremor and dystonia are so commonly intertwined that it's very difficult to differentiate cases where really tremor is a different condition from dystonia. Let us now review each item in the new classification. At first, family history. We try to understand or draw the pedigree and to see what it suggests, whether it is an autosomal dominant pedigree, an autosomal recessive pedigree, and so on and so forth. We do not receive here information from the lab. We collect information from the patient and caregivers. If there is no familial occurrence, of course, dystonia is considered sporadic. There may be uncertainty because mild signs of dystonia are easily overlooked. There can be some family members who are reported to have mild tremor or mild twisting of some body parts, and it's up to us to interpret whether we consider this part of the phenomenology of dystonia. Of course, the family history focuses on dystonia, although a large percentage of individuals with dystonia may have family members with isolated tremor. Again, at this stage, the distinction between tremor, which is part of the phenomenology of dystonia, and tremor, which could be a separate entity, remains a difficult one. The next item under axis 1 is body distribution. The headings here are the same as in the previous classification, but there are some interesting differences. Of course, in focal dystonia, only one body region is affected. This is unchanged. In segmental dystonia, 2 or 3 contiguous body regions are affected, and these shouldn't qualify for hemidystonia because in hemidystonia there is only one body side and can be 2 or 3 as well. In multifocal dystonia, there is involvement of 2 or 3 non-contiguous body regions that does not correspond to other specified patterns. We agreed in the consensus that bibrachial or bicrural forms are considered multifocal. In hemidystonia, there is unilateral involvement of the upper and the lower limbs with or without trunk, neck, or cranial regions. And generalized dystonia has been redefined in a very pragmatic way as a pattern of distribution that goes beyond segmental or multifocal and does not qualify for hemidystonia. The assessment of body distribution has further been expanded by adding a list of body regions affected. We realized as a panel that the synthetic expressions focal, multifocal, segmental, generalized were used in a very inconsistent way across different centers, different countries, and different times. So we thought that it could be valuable to have a simple listing of body regions affected, and we provide a basis for this listing by identifying 7 body regions: upper face, lower face, neck, larynx, upper limbs, trunk, and lower limbs. You will see later on in the data capture form that these are listed in a way that each assessor can check where he sees any dystonia. Temporal dimension has 3 subdivisions. The onset of dystonia can be acute, meaning in the number of hours or one or few days, subacute, meaning in the number of days or weeks, or gradual, meaning in a number of weeks, months, or years. This indicates the first occurrence of symptoms or signs of dystonia until the first peak of severity. The disease course can be static, meaning persistent, or progressive with worsening, or fluctuating with variations in intensity or distribution of dystonia. This indicates the course of dystonia from inception until clinical evaluation, and it may change with longer durations or observations. Variability can be paroxysmal with diurnal variability or no variability. This indicates changes in intensity or phenomenology of dystonia over shorter time periods than are considered under disease course, typically measurable during a day. Under phenomenology, we consider the relationship with voluntary movement. Dystonia can be task-specific or action-induced or also present at rest. Dystonia is task-specific when it occurs only during a particular motor activity or task, for example, writer's cramp or musician's dystonia. Action dystonia is induced by a variety of voluntary movements which involve the affected body part without specificity for a certain task or activity. In this case, an upper limb dystonia would appear not only when a patient writes or sings, but also when he does other tasks with the upper limb. When dystonia is fixed or immobile, the normal posture is relatively constant and often cannot be significantly changed by passive movements. Additional characteristics are the alleviating maneuver, whether dystonia is tremulous, tremor-like, or jerky, myoclonic-like. Dystonic movements with a tremor-like or rhythmic or quasi-rhythmic or jerky quality are listed. If tremor or jerkiness are instead considered an independent movement disorder coincidental with dystonia, are listed under associated features. Finally, dystonia can be isolated if there is no other motor or neurological feature of note, or combined when there are other features that go together with dystonia. Can be combined with another movement disorder, for example, myoclonus, tremor, chorea, Parkinsonism, ataxia, or dystonia can be combined with other neurological features, for example, corticospinal signs, epilepsy, developmental delay, combined with systemic features such as liver disease, for example, in Wilson's disease, or non-neurologic visual defects. Tremor and myoclonus are listed in this section when they are considered separate entities. For example, in the case of myoclonus dystonia related to CGCE variants, we consider myoclonus a combined condition, so we consider this here. In Wilson disease, as I said, or in cases of dementia, there are other neurological features. In ataxia, there is another movement disorder. Let us consider now axis 2. This is the 2013 version where two entries distinguished inherited or acquired dystonias with subdivisions considering inherited, acquired, or idiopathic dystonia from nervous system anatomy. This traditional organization of axis 2 was reminding of the previous classifications on dystonia that were based on a single axis that didn't differentiate between axis 1 and 2. We now worked on this organization and considered a better distinction of the different items in axis 2. The current axis 2 recognized four main divisions: genetic, acquired, neuroanatomical, and pathogenesis. The fourth is completely new. We discussed within the committee whether to have an axis or a subdivision on pathophysiology, and then in the end, we recognize that times are not ready for having a pathophysiological division, and so we remained with etiology and pathogenesis. The name of axis 2 is also changed, not just etiology, but also etiology and pathogenesis to reflect this change. The color code is the same as mentioned before. In green, we see the introduction of the new section, pathogenesis. In blue, we see that the main changes here are in the section for anatomy. But let's consider the different items orderly. In the first column, genetic, we recognize whether we have a gene, and we classify here the gene according to the gene transmission as autosomal dominant, autosomal recessive, X-linked, or maternal. We may not find any gene, or we may not perform genetics. So we have the last hypothesis, the last item, which is unknown. Unknown means either that we didn't perform the assessment or that the assessment was unremarkable. Of course, we can accept the fact that there will be new genes being discovered in the future. So whatever point in time we consider, we can always retain the fact that the study, the genetic study, may be incomplete when looked at from subsequent knowledge. The second column is acquired, whether there is a pathogenic or one that we consider pathogenic cause, such as medications, toxins, trauma, or any other cause that we have to list specifically. Or also here we can have unknown, meaning that we have no information or that the information we have is not providing us any clue to what the pathogenic acquired cause could be. In the third section, we have neuroanatomy. We may identify a focal lesion or a multifocal lesion or a diffuse lesion or no lesion. In all these three columns, we have to mark whatever is likely pathogenic. So we don't mention a gene that is not clearly pathogenic based on current knowledge, or a cause that is not evidently pathogenic, or a lesion that is not clearly related to dystonia. In the fourth column, we have the pathogenetic process, whether we consider this dystonia a developmental defect, a degenerative condition, a metabolic condition, an immune or inflammatory condition, or whether we don't know. In all these cases, we have the last item indicating unknown because we may lack information or we may have unremarkable results. Idiopathic is a term that doesn't immediately appear in the classification. It is idiopathic, a form of dystonia that is marked as unknown in the last three columns. So unknown in genetic, unknown in acquired, or unknown in neuroanatomy. The new dystonia classification also contains a data collection form that is meant to facilitate data collection and also storage into an organized database. Let us look at the details. In the upper part of the data collection form, there are the items related to axis 1. And here you see on the right that body distribution have a summary distribution and a body regions involved distribution. You see in the data collection form that there is space for additional information, and there are asterisks. One asterisk indicates that we have to choose in a given section one item only. Two asterisks indicate that we can choose in a given section as many items as we like. So for example, in the summary distribution, we have to choose whether it is focal, segmental, multifocal, etc. But in body regions involved, we can list all the regions that are affected. Again, onset, we have one choice, course and variability, also one choice, and age at onset, of course, one choice. But in the relationship with voluntary movement, we can have a form that has more than one occurrence. And also in the additional characteristics, we can have more than one occurrence. If we go in the bottom part of the form, we see that we can have dystonia isolated or combined. And if we mark isolated, it's specified here into brackets that if this is checked, combined items must remain unchecked. So there is a specification. If we say it is isolated, we can have no item under the combined. But if it is combined, on the other hand, we can have more than one item checked. Axis 2 is also in the bottom part, and here we have one choice only for genetic, one only for neuroanatomical, one only for acquired, and one only for pathogenesis. There are further instructions in the bottom part of the section and also specifications here. So I wish to summarize what we have said so far. From the two-axis revolution in 2013, we tried to evolve into the two-axis evolution in 2025. There are few changes, few additions, but essentially a detailed reorganization and revision of what had already been done 12 years ago. There is a practical approach and the cure of many details in the hope that this new classification can be more easily implemented by clinicians and by researchers who have no clinical practice. We have specified terminology in a better way throughout the publication. If we use the data collection form, we can easily collect information on the clinical characteristics of axis 1 and on the etiology and pathogenesis of axis 2 and follow the patient over time, having more and more of these assessments, with the latest one representing the most updated information that we have. But it will be also at the same time easy to go back to the previous patient condition through the data collection form. Let's now consider what could be called the dystonia conundrum. We saw before that dystonia, myoclonus, and tremor have some overlap. Between dystonia and myoclonus, there is an overlap that we usually call jerky dystonia. Between dystonia and tremor, there is another overlap that we call tremulous dystonia. But also we have to consider that an additional overlap has been reported is the so-called dystonic tics. However, in the case of dystonic tics, this is just a description to indicate that tics look a little bit like dystonia, but has not much to do with dystonia because tics are indeed a separate entity from dystonia. This is not the case between dystonia and tremor that have a very significant overlap where the term dystonic tremor has been used to indicate tremor that really is part of the dystonia phenomenology. In the 2013 classification, dystonic tremor was considered a possible phenomenology of dystonic movements. Here you see condition, category, and phenomenology on the left. The condition is dystonia. The categories are dystonic movements or dystonic postures. And under dystonic movements, you can see that there can be tremor, which could be called dystonic tremor. That was the usage at the time of the 2013 classification. However, 5 years later, in 2018, a tremor consensus was developed. This tremor consensus introduced also for tremor the same double axis category that we introduced in dystonia. But the tremor experts used the term dystonic tremor in a different way. They considered that dystonic tremor was a bridging, a connecting term between tremor and dystonia. So whenever the condition was double, there were tremor and dystonia at the same time, the word dystonic tremor could be used. This created a difference with the original usage of the dystonic tremor term made by experts in dystonia. So if we look at this overlap in greater detail, we can see that there was a discrepancy between the 2013 consensus made by dystonia experts and the 2018 consensus developed by tremor experts. The definition of the dystonia consensus was that dystonic tremor is a dystonic movement. The definition of the 2018 tremor consensus was that dystonic tremor is tremor in a body part affected by dystonia. Having these considerations in mind, the 2025 dystonia consensus didn't use the term dystonic tremor and instead it discouraged using the expression dystonic tremor and preferred to honestly admit that dystonic movements can have a tremor-like appearance or a jerky appearance, which could resemble tremor or resemble myoclonus, and leave to the treating physician to realize whether the phenomenology they are seeing is considered part of the dystonia phenomenology or a combined different movement disorder combined with dystonia. A recent report reviewed the number of cases with tremor appearing in patients with dystonia. You see from the bars here that there is a lot of overlap. In some series, it goes up to 70% of dystonia patients who have tremor. In other, it goes down to 11, 13, or 17%. In any case, it's a very high percentage. Many patients with dystonia have a tremor-like phenomenology. So really, the distinction between tremor and dystonia is very much challenging. It has been proposed that there could be ways to separate neurophysiologically tremor from dystonia. Here you see in the image on the left that the head position has some jerks, and so it has a more jerky or jerky dystonia-like appearance. In B, you see more of an oscillation, so it's more rhythmic and more tremor-like appearance. In C, on the right-hand side, you see that there are oscillations overlapping to quick displacements or jerks. This is theoretically useful. In practice, not as much as can appear from the graph, but probably there are also cases where the mix is even more in between these representations. So this committee that met also in 2025 proposed to retain the terms dystonia and tremor, of course, these two terms, the main terms, to accept when it is clearly defined in a publication or in a clinical observation, the terms jerky dystonia, tremulous dystonia, or tremor associated with dystonia, and avoid expressions such as dystonia tremor syndrome, dystonia with tremor, dystonic tremor, or tremor dominant dystonia. To summarize, the term dystonic tremor was introduced by Stan Fan to differentiate tremor observed in dystonia from cerebellar tremor, Parkinsonian tremor, and essential tremor. Usage of this expression will continue, notwithstanding published consensus discouraging its use. I've seen very recent publications that have, even in the title, the expression dystonic tremor. The new phenomenological section of Axis 1 is, however, expected to facilitate recognition of proper relationship between dystonia and tremor. And I hope that if we collect enough data, we can use the data capture form to see maybe in 5 or 10 years what is the opinion of the neurologists who are collecting data. Do they really think that in the majority of cases tremor is an expression of dystonia, or will they consider that there is a significant proportion of patients where dystonia and tremor coexist as separate entities?